All right, let's jump right in. We're going to talk about something super important and honestly pretty fascinating: pharmacokinetic drug interactions. Sounds complicated, right? But stick with me. We're essentially going to follow a drug on its journey through the body to see how one pill can totally mess with another one. And trust me, understanding this is key to making sure medications are safe and, actually work. So let's get into it.
So here's what we've got on tap. First, what even are drug interactions? Then we'll track a drug through its 4 big life stages: absorption, distribution, metabolism, and excretion. You might hear people call it ADME. And at the end, we'll bring it all home and talk about why this stuff really matters.
Okay, so let's kick things off with the big question, the one that got us here in the first place. How is it possible that taking one medication can completely change what another one does? I mean, it could cancel it out, or even worse, crank its effects up to a dangerous level. It's a wild puzzle that's playing out inside our bodies all the time.
Well, the whole secret is in what we call a drug interaction. It's basically any time one thing, and that could be another drug, some food you ate, whatever, messes with the activity of a medication. And that can go a few ways. Sometimes it boosts the effect, which can be good, but other times it can make the drug useless, leading to treatment failure, or it could even create a brand new toxic effect.
Right, so these interactions aren't all the same. They generally fall into 2 big buckets. You've got pharmacodynamic ones. That's when 2 drugs are fighting over the same parking spot, the same receptor site, but that's a story for another day. Today, we're zeroing in on pharmacokinetic interactions. This is different. This is all about what happens to the amount, the concentration of the drug floating around in your system. It's not about the drug's action, but what your body does to the drug itself.
And to really get a grip on this, we're going to use a little roadmap called ADME. Just think of it as the 4 chapters in a drug's life story. A is for absorption, getting into the blood. D is for distribution, traveling around. M is for metabolism, getting broken down. And E is for excretion, getting kicked out. Simple, right? The key thing to remember is that an interaction can pop up and cause trouble at any one of these steps.
All right, let's dive into Chapter 1, Absorption. This is all about the entry point. How does that pill you just swallowed get out of your stomach and into your bloodstream where it can do some good? Well, as you can probably guess, the gut is a real hotspot for interactions. A lot can go wrong here before the drug even has a chance to start its mission.
So what can throw a wrench in the works during absorption? Well, there are a few main culprits. First, you could have changes to the environment itself, like the pH level, the acidity of your stomach. Then there's this really interesting physical thing called chelation, where drugs basically get tangled up and form little clumps that can't go anywhere. And finally, just the pure speed of your GI tract. How fast things are moving along. That can totally change the game.
Let's make this real with a classic example: chelation. Okay, picture this. Someone takes an antibiotic, say tetracycline, but they take it around the same time as an antacid, which is full of stuff like calcium. What happens? In the stomach, that antibiotic and the calcium literally grab onto each other. They form this big, useless, insoluble clump. It's like they've handcuffed themselves together. And this new clump is way too big and bulky to get absorbed. So what's the result? The antibiotic becomes pretty much useless. It never even makes it into the bloodstream to fight the infection.
Okay, so let's say our drug made it past absorption. Whew, now it's officially in the bloodstream, the body's superhighway. This brings us to our second stage, distribution. This is all about how that drug gets from the highway to its final destination, the tissues where it needs to work. But here's the thing, it doesn't just wander around on its own.
You see, a lot of drugs are kind of like passengers. They need to hitch a ride on proteins floating around in the blood, especially one called albumin. Think of albumin as a fleet of taxis. Now, what happens if 2 different drugs are trying to hail the same taxi? They compete for a seat. The one that loses the competition gets kicked out onto the street. It's displaced. And this is where it gets really important. Only the free drug, the one walking around on its own, is actually able to do its job. So if a bunch of it gets kicked out of its taxi, you suddenly have a much higher concentration of active drug. And that can quickly become a big problem.
And this really highlights just how dangerous this can be. That sudden spike in free drug can push the effect way into the toxic zone. The textbook case for this is when an anti-inflammatory drug, phenylbutazone, boots the blood thinner warfarin out of its protein taxi. All of a sudden, you have a flood of free, active warfarin in the system. The person's blood gets way too thin, and their risk of a serious bleed goes through the roof. It's a perfect example of why this stuff has to be watched so carefully.
Okay, now we're getting to the main event. This is probably the single biggest area where drug interactions cause major problems: Metabolism. You can think of your liver as this incredible chemical processing plant. It's packed with enzymes that are constantly working to change and break down drugs, usually getting them ready to be kicked out of the body.
And inside this liver factory, you've got two main forces at play, and they're complete opposites. First, there's enzyme induction. This is when one drug comes in and basically tells the factory workers, the enzymes, to speed up, work overtime, so the other drug gets processed and cleared out way too fast, and it might not work at all. Then you have the opposite, enzyme inhibition. This is when a drug comes in and throws a wrench in the machinery, blocking the enzymes. The assembly line grinds to a halt. The other drug can't get processed, so it starts to build up, and that can lead to some serious toxicity.
So let's talk about induction, speeding up the factory. A famous example is a drug called phenobarbital. It's a major inducer. It puts the liver's enzymes into hyperdrive. Now imagine someone is also taking that blood thinner, warfarin. The supercharged enzymes just chew through the warfarin at lightning speed. Its effect is gone. And what happens when a blood thinner stops working? The patient is left unprotected with a huge risk of forming a dangerous blood clot.
And if you want to see just how powerful induction can be, just look at this number. There's an antibiotic, rifampin, that is one of the strongest inducers we know of. It can make the liver metabolize a sedative called midazolam up to 20 times faster. Let that sink in. 20 times. That basically means the midazolam is getting wiped out before it can even do anything. It becomes completely useless. That's a mind-blowing effect from just one interaction.
Okay, now let's flip to the other side, inhibition, or gumming up the works. And there is no better example of this than the brutal interaction between alcohol and a drug called disulfiram. See, when your body breaks down alcohol, it creates this nasty, toxic chemical called acetaldehyde. Normally, an enzyme gets rid of it right away, but disulfiram blocks that enzyme. It puts up a brick wall. So if someone on the drug has a drink, that toxic acetaldehyde just builds up and up, causing an absolutely miserable physical reaction. We're talking intense nausea, vomiting, pounding headache. It's a terrible experience, but it's a perfect demonstration of what happens when you shut down an enzyme.
So, our drug has been absorbed, it's traveled around the body, it's been processed by the liver. What's next? Well, it's got to leave. This brings us to the final leg of the journey, excretion. This is the exit strategy. And for most drugs, the main doors out of the body are the kidneys.
And just like with the protein taxis earlier, a lot of interactions here come down to competition. Think of the kidneys as having these revolving doors, or transporters, to push drugs out. If two drugs are trying to use the same door at the same time, you get a traffic jam. A really cool example is how probenecid can block the exit for penicillin. It basically holds the door shut, which keeps penicillin in the body longer and makes it work better. That's one of those rare times an interaction is actually helpful. But then there's the dark side. Something like an NSAID can actually reduce blood flow to the kidneys, slowing down the whole waste removal process. And for a drug like lithium, that's incredibly dangerous because it can build up to toxic levels really fast.
So, there you have it. We've tracked our drug all the way from the moment it's taken to the moment it leaves. So what's the big takeaway? Why does any of this matter? It really all boils down to one single crucial thing: patient safety. This isn't just some abstract science lesson. Getting this stuff right is absolutely fundamental to keeping people from getting hurt and making sure their medicines actually do what they're supposed to do. Look, here's the bottom line. At every single step of that journey, absorption, distribution, metabolism, excretion, an interaction can sneak in and either crank a drug's level up to dangerous heights or drop it so low that it's useless. It can lead to severe toxicity or complete treatment failure. Now, yes, sometimes we can use an interaction to our advantage, but it always has to be managed carefully. And this is 1,000 times more important for drugs with what's called a narrow therapeutic index. Those are the ones where the line between a helpful dose and a harmful one is razor thin.
And that brings us to one last really big question for the future. You know, it's becoming more and more common for people to be on a whole handful of different medications. It's called polypharmacy. And as that happens, this web of potential interactions just gets bigger and more tangled. It's like a giant spider web of what-ifs. So the real challenge moving forward is, how are we going to keep up? How can we predict and manage all of this to keep people safe? It's a huge question and something we all need to be thinking about. Thanks for sticking with me through this journey.